going to be an education. So no matter what field of business that everyone is in, the new normal is going to be way different than February was, and making those adaptations so that people feel safe to frequent your business is really going to be a big part of the reopening process. Again, we can leave this informally, but I did have a few slides. If you'd like me to present the slides, I'll go ahead and do that. I'll share my screen to do that. Is that okay, Megan? Go ahead. Should I go ahead?
Absolutely. Go ahead. Thank you.
Okay. So, oh, and just one before I share, there's one other thing that I just wanted to bring up for Dr. Rubino, and these are the hoods, by the way. These are the Stryker hoods that are used in the operating room. And so the helmet itself is what you keep. That's this right here. That's the helmet. And then there's a disposable piece that goes over it. And so you would be.
I can see what you're looking at.
You cannot. Am I sharing my screen?
A PowerPoint.
Oh, okay. You know what? Let me. My apologies. I thought I was sharing that also. So let me just stop sharing that for a second, and then it gave me a bunch of options of what screen to share. So I thought I could share them all. But right here. So let me share this. So these are the orthopedic hoods here. And so we use this for joint replacement surgeries. And this is what the hood, the permanent looks like. It has a fan so that it circulates air. And it just fits on your head like any other helmet. And then the disposable piece is the covering of the helmet. So the blue and the white plexiglass. And if you use loops or if you use a light for your procedures or when you're doing your work, you can use all of that within the helmet. Some of the helmets will actually come built in with a headlamp, and then you can use your loops on top. And so I thought this might be something for a dental practice that would be helpful. The only thing about the hood that goes over it is that there's a little bit of a hole for the fan so it can circulate air into your suit. And I'm not sure you'd actually want that. So you could cover that potentially with one of the, like an N95 mask material. You could actually just sort of almost tape the material over it. And that might be something that would be useful. So I'm gonna stop sharing that screen. But that's something I've been, the dentists have a particular challenge ahead of them with the pandemic and the aerosolization. And so hopefully the testing will become prevalent enough that that won't be an issue. And then let me share the PowerPoint talk just a little bit. And again, feel free to unmute and interrupt any point. So this was a presentation that Lori had set up that we had given to some IBGI patients. And just to go through it quickly, you know, COVID-19 is the name of the disease that the coronavirus causes. And so COVID-19 stands for coronavirus disease, and obviously the 19 is for 2019, which is when this emerged. And then the virus is called the SARS-CoV-2 virus. The SARS-CoV, I guess 1 before it was called that, was the SARS outbreak in 2003. And so this is the virus that causes this disease, much like HIV is the virus that causes AIDS. And so just in terms of nomenclature, that's one way to think of this. So COVID-19 being the disease and the coronavirus obviously being the virus, which is a severe acute respiratory syndrome. That's what SARS stands for. And it's very contagious and it's potentially deadly. And some people, we just don't know who, and that's the other part of this that makes it so difficult. And pandemic simply means that it's worldwide. The outbreak is not confined to a town or a state or a country. It crosses borders and is all over the world. And an epidemic is one that's confined to a city or a state or a country. It's a novel virus. None of us have ever seen this before. None of our immune systems have seen it before. The thought is that it originated in bats. And the fact is there are hundreds of coronaviruses that exist in the animal kingdom, and there's subtypes of alpha, beta, delta, gamma, but there are 7 that are known to be in humans, and 4 that are quite common and generally harmless, and then 3 that are less common and quite harmful. MERS is the Middle Eastern Respiratory Syndrome virus that emerged in the Saudi Arabian Peninsula, and it was transmitted by camels to humans, but it's very deadly. And so it really didn't have a chance to spread because it would actually kill the host before it spread. And so the human-to-human transmission wasn't very robust, but it was certainly a concern. There's no vaccine for MERS. The one is emerging now. and that might be helpful in our search for a vaccine for SARS-CoV-2. SARS-CoV-1, this is the SARS outbreak in 2003, and there were 8,000 infections worldwide and about 800 deaths worldwide, but the World Health Organization spent $40 billion to contain this outbreak. And when you think back on that, that seems like money very well spent, that you contain the outbreak worldwide for $40 billion. That seems like a bargain when we compare it to what's happening today. So what is COVID-19? It's an illness, and it's caused by this virus, and it's really characterized by fever, cough, and shortness of breath. It's a respiratory illness. Other symptoms that can define the illness, I think loss of taste or smell is the most curious. You're starting to hear about COVID toes, the blue toes that can form. But any of these symptoms can be potentially consistent with a COVID-19 infection.
What are the blue
And it's,
toes?
yes?
What are the blue toes?
So we're not certain what happens, but there's been an observation that some people in their toes develop like bruises and splotches. If you look up COVID-19, or if you look up COVID toes on Google, you'll see these pictures of toes that have bruises. And there's an interesting thing that happens with the coagulation system in the body for patients who've been severely affected with COVID-19, and they have a real trouble with blood clots. And the COVID toes are actually happening in people with a less severe infection, but there might be something about the virus that precipitates blood clots. So the COVID toes might be small blood clots that occur. So if you see sort of splotches on the toes, that's been an observation that people have seen for patients infected with the coronavirus.
Is that why children seem to be infected with Kawasaki's? Is it the same thing with the rash and the?
It's really curious. The Kawasaki's may not be a result of a blood clotting phenomenon, but you do see the rash and a Kawasaki-like syndrome. They also talk about a toxic shock syndrome. And toxic shock can not infrequently present with showering blood clots, bruises in the toes or in the fingers. So, you know, I don't think anyone's fully has it figured out, but it's certainly an observation that people have made regarding patients infected with this coronavirus that's going around now. So there's a lot to learn, and the sheltering in place has actually given us some time to learn. That's really the huge benefit of it from a medical standpoint, is biding time, getting more information, and also developing some time for therapeutics and vaccines. This is how it's spread by respiratory droplets. So whether you're sneezing, where this is pretty dramatic, or just speaking, the respiratory droplets can be inhaled by somebody else, or they can land on surfaces, and then you touch those surfaces and touch your eyes or your nose or your mouth. And we learned very early on in medical school that most viruses are transmitted by touching your eyes, touching your nose, touching your mouth. And then you want to avoid close contact to stop the spread of the disease. And this is all from the CDC website. And so I've been directing my patients to the CDC website. I would recommend that you direct your clients to the CDC website. It's very robust. It's very helpful. If they know about it before they come to your store or come to your business, it's really, really helpful. They have things like how to make your own cloth masks on the CDC website. And this is the one that I made, and I wore it at work for about a week just to let patients know how simple it was to make. I made this out of a pillowcase. And then some of the risk factors for getting a severe illness: patients who have lung compromise, heart disease, immunocompromised from medications or from illnesses like lupus, patients who are obese, which is unfortunately a third of our population, patients who are older, patients with diabetes, and patients with liver and kidney disease. These are patients who, if they get the coronavirus, may have a more serious disease, may have a more serious course of COVID-19. And while these people are at higher risk, it's looking like anyone can develop a serious illness, and that's what makes it so difficult to manage, is that, you know, you can't just be 50 and healthy and be guaranteed you're going to be fine. And so that's the hard part. Chances are you'll be fine, but certainly there are people who have been healthy and have gotten ill, and seriously so. And we've all seen this, the idea of flattening the curve, and that without any protective measures, this one would have run its course very, very rapidly and would have flooded the medical system. And you saw it in New York. New York was nearly spilling over in terms of their ability to handle the virus. We actually did see it in Italy. Italy, it overflowed, and the doctors in Italy were talking about making these very difficult decisions about keeping some people on a ventilator and taking them off, and basically taking a scarce resource. And then as we learn, you know, time has helped us. The ventilators aren't as helpful as we would have thought, or as we would have hoped, because people who get on a ventilator not infrequently die on a ventilator. And that rate is anywhere between 60 and 80% of people who don't make it once they're on a ventilator. So it's a very, very tough disease, tough illness when it gets to that stage. What we're hoping to do is, by flattening the curve, and we're really just pushing the date back. We're moving the date down the road that you might get infected. But the hope is, at this green line, there'll be a therapeutic or a vaccine, or more understanding of the transmission, so that all of these people can be protected from getting the disease in the first place. Whereas if we just let it rip, and then you have this, and you know, Sweden is a model where they're quote unquote letting it go, but don't kid yourself. Sweden is practicing social distancing. They are sheltering the vulnerable. They have a very robust testing and surveillance capacity. So if they identify a case, they're able to track down their contacts. They can do the contact tracing. So though they are letting things more open, they're actually better equipped to do it than we are. And that's been our big problem, is our lack of tests. And you know, testing requires people, places, and things. And so you need lots of people to administer the tests. You need places to do it, like these drive-through sites. And you need things, these swabs. And these swabs are in very short supply. The reagents to use for the swab to see whether or not you have the disease, so the solutions that you mix it in, those are in short supply. And so we really don't have all the people's, places, and things that we need to make the tests more abundant. And you know, ideally, we'd all walk out our door, we'd spit in a cup, and that would be our test. And the test says, you're positive, go back inside for 2 weeks, or you're negative, go out and live your life. And if everyone were able to do that, we would get the economic benefit, and we get the medical benefit of containing it. So I don't want to understate the importance of testing. And though it's a wish list that we could all be tested every single day, that's ideally what we should be shooting for. You know, short of that, then you test and contact trace.
I have a question on that.
Yes, please.
So if testing, you know, how do we know if a test is a good test? Like, because there's all these tests, right?
So,
and everyone claims to have it.
Well, you're gonna. I'm gonna talk about that in just a second. But a good test obviously gives you a positive result whenever someone has the condition or disease, and gives you a negative result every time someone doesn't have the disease. And so we know that with the PCR test, which is actually putting a swab into the nose, that about 70 to 80% of the time, when you have the disease, the test is positive. But there's about a 20 to 30% false negative rate. And it might be because of sampling. You really got to get it back in the nasopharynx. You got to get it way back there. You see where the swab is? And people will say it feels like it's like swabbing their brain. And so there's a lot of, I know that, I love that. I love your expression, Megan. I totally agree. And so there is there's a big movement towards saliva testing, different types of tests besides PCR that are faster. If you want to look up a term that's interesting, it's CRISPR, CRISPR. That's a type of test that could be done at home, doesn't require as much of the equipment. And CRISPR has been used to splice genes for therapeutics, but it also might be able to be used in a diagnostic setting. And it can give you a result within a couple of hours. And so some of the companies that are in the CRISPR therapeutic section are kind of putting attention to the diagnostic portion of the utility of that type of technology. So this is DNA technology that's very advanced, very cool, but not quite here yet for COVID. And then blood testing. So this is a swab test. You know, you take some of your solutions from where your respirations are, because it's a respiratory infection. A blood test is used to tell you if you've had the infection. So the swab test will say, are you carrying the virus currently? But a blood test will tell you, have you already had it? And a lot of us have had flu-like symptoms over the winter time. I was absolutely convinced I had this. A friend of mine who's an ER doc had one of those finger stick antibody tests. And even though I know I really shouldn't put any stock in it, I just took it anyway. And to my chagrin, it wasn't positive. It was like, I haven't taken a pregnancy test yet, but it was just like one where the stripe comes on or doesn't. And when it didn't come on, it was very disappointing. Because it would be great to be that person who's had the virus, didn't really know you had it, and you're on the other side of it, you have antibodies. And though we don't know whether or not you're immune for a lifetime, you're probably not going to get a severe infection if you have antibodies. And in fact, we're using antibodies to treat people who are very sick. So people who've had COVID-19 are donating their antibodies to the blood bank. And then those antibodies are being transfused to people who are really sick. And they've had very good results with it. So just again, to answer your question a little bit better about testing, what makes a good test, I put this chart here. So if you're antibody positive, and then every test should be positive. And this is sort of the incidence of, let's say, the infection in the population. So a study out of Stanford said about 2% of people have antibodies. So we're not that far into this. In New York, it's about 15% because they got overrun. So we're probably anywhere in the country between 2 and 15, 2 and 20% into this process. And so 20 out of 1,000 people have antibodies. And the perfect test will have no false negatives and no false positives. Does that make sense?
Mm-hmm.
And so that's what a perfect test looks like, where every positive test is for a positive antibody and every negative test is this. Now, the reality is each of these tests has their limits. And so a good test is about 80%, we call it sensitive, meaning there's about a 20% false negative rate. And so 20% of 20 would be about 4 people who, even though they carry the antibody, their test is negative. And then a good test in terms of false positives, actually it's much easier to design a test that doesn't have a lot of false positives. So it's about 1%. So about 980, 1% of that would be 10 people. But now fill in the rest of the box. And all of a sudden, if you get a positive test result, it's really not that informative. It's almost like a coin flip of whether or not you really have the antibody or not. And these numbers sort of, it's a funny way with math, but this is actually how it is. And what happens when the disease becomes more prevalent? So let's say it's not 2%, but 10%. So when it's 10%, the numbers, you still have the exact same test with 20% false negatives and 1% false positives. Then you fill in the rest of the numbers, but all of a sudden, you know, there's a much better chance that if you get a positive test, you actually have the antibodies. So it's just a funny thing with the numbers. And so when people are talking about the test not being so great, part of it is simply because the predictive value of the test isn't where it needs to be at this point in the whole epidemiologic spectrum of COVID-19. So that's a pretty advanced statistics course right there, by the way. But that's some of the limitations of the test. And again, I keep directing everybody to the CDC website. They've done a marvelous job at getting information into hands of the public and the information that they really need. I've actually printed some of these out. I had my son put the little IBGI logo down here on the CDC. It's taped up to the plexiglass that the patients come up to. So we have the CDC guidelines right where patients can see them. And you know, I think that's really important. And again, helping your customers and your clients feel safe. What we've been telling patients if they're injured is, you know, look, we understand you're supposed to be practicing social distancing. You're scared to come to our facilities because of an infection transmission. And so we do sort of give general advice. Hey, look, rest it, ice it, compress it, elevate it, do what you need to do at home. You can even make a makeshift splint out of a towel. But we're afraid too many people are doing this. They don't come in and see the doctor. And you know, you hear about the cardiologist talking about no one seems to be having heart attacks these days, and no one seems to be suffering from congestive heart failure. They're not coming into the office. The fact is those people actually are suffering heart attacks and are suffering from congestive heart failure, and they're not getting treated. So we really don't want this to be an option, and I'm sure this applies to your line of work. And these are some of the examples. This is a really shattered wrist. It doesn't look so bad, but this portion of the wrist belongs right up in here. So this thing is offset a full width of the bone. It's fully back and it's tilted backwards. And this was in an older gentleman whose daughter didn't want to bring him in, scared to death. His hand was 3 times as big as it normally is. This is all swelling here. That skin is usually right next to the bone. And his arm was purple and swollen and he was carrying it like this. It was terrible. And that was a neglected injury because of the virus. And they come in 5 days later, it's just harder to treat. This was another one that I saw. This was an older woman who fell coming out of her house, and her shoulder is totally out of joint. It should be up here, and you can see the ball down here. And she didn't come to the doctor's office for 3 days. And she called 911. The paramedics came, and they brought her back into the house because they didn't want to bring her to the ER because, you know, everyone's scared about getting the care that they need. And when the son brought her in 3 days later saying she had shoulder pain, I was like, I'm not sure I can get this back in the socket. We got lucky. She did get it back in the socket. She was able to avoid the ER. But these injuries don't get better with neglect. So we're trying to tell our patients, don't make a problem worse by neglect. We offer several avenues for patients to see us. and ortho access and a doctor's appointment have been the way that I've seen most patients. But now telehealth, we do this for all of our appointments, by the way. We temperature check, we screen, we do frequent disinfection. Our office kind of smells like a swimming pool because we have so much bleach, and everybody's masked. And we're trying to create a culture where if one of the doctors like myself puts our mask down, that anybody in the office can say, "Doc, do you mind putting back on your mask?" And instead of my saying, "You don't tell me what to do," the answer should be, "Thank you so much. And thanks for reminding me." And these are some of the culture changes that we're going to need to make in order to keep everybody feeling safe. And then obviously lots of opportunity to hand wash and sanitize. And the thing about Purell, one of the best statements I heard about Purell is, if you use enough of it, it'll make you want to wash your hands. And so there's nothing better probably than soap and water. But we have plenty. We don't have plenty of sanitizer. We've had to remove sanitizer from all of our exam rooms because people have been coming in for that. They've been taking it. And then telehealth, this is our new way of doing business. And here we are on Zoom, same idea. You need a camera with you need a camera and you need a microphone. And all of a sudden you can do telehealth. And this was the definition from the Department of Health and Human Services, but that's not really important. What was interesting was that 29 states allowed for telehealth and the rest didn't. And as of February, I did 0 visits, and now I've done a couple of hundred. Our office has done several thousand. Our therapy has done several thousand visits because of this. This virus has made it so that telehealth is now good to go. Everybody's using it. It's totally deregulated. We do have, this was our first sort of regulation. I mean, you can see it was very simple. It's a little bit more complex now in terms of how we code and bill and everything else. But the fact of the matter is, it's still in its nascency. It's relatively unregulated, but it's been very helpful, allowing patients not to be neglected with the type of injuries that they would typically present with. And we like to say that there are pros of telehealth and this idea of we can practice social distancing, we can decrease risk exposure. So if you can figure out a way to utilize it for your benefit, you should. It's very convenient, and patients have loved that portion of it. But obviously there are limits. And as an orthopedist, we rely very heavily on physical exam findings. We're always pulling, tugging, pushing, trying to figure out what's wrong. And then we also do a lot of testing, like the x-rays. Those paramedics didn't have an x-ray like I had to know that that shoulder was dislocated. And so they brought her back into the house. So you obviously give up some things when you do telehealth, and you're going to have to figure out the pros and cons for yours. And for us, we rely more heavily on our history. So what you tell us, we will put more weight to, and we have to rely less on physical exam, though we have people, doing this type of thing on a telehealth visit. The nuts and bolts of it are just like what we did here. You pick a time to meet and you meet, and you need a camera and you need a microphone, and we set a time, and because without a set time, we won't know. And so this is our platform that we use. We use DoxyMe, DOXY.me, as in doctor, see me, doc, see me. And it's been very effective, very helpful. When we send out an invite, we do it by email or a calendar invite or text message. So a patient gets a URL. This is mine, and it's mine permanently. This is my waiting room all the time, so it's set. And then when they click that link, this is what they see, the patient see on their phone or on their computer. And they type in their name. I typed in patient 0. And then when they check in, they press the check-in button. They're being told to enable the camera. And then once they enable the camera, we're like in a Zoom meeting, but they wait for me to join.
So does that
And
mean
so
I can join you anytime? I can ask for an appointment anytime?
you can, I just won't be there every time. So that's the thing. So I still have you call Marianne. I have you call Liz's mom. Because Elizabeth's mom's and I've been working together for over 10 years. And so Marianne will set the appointment time so that we're there at the same time. Because you can check into the waiting room and nothing will happen unless I'm logged in on my side. And what happens on my side is I see that you're checked in. Here's patient 0. So you could log in tonight and you can hang out in the waiting room. You're welcome to do that. But I'm not going to be there. And the idea, at some point, we'll probably have a template where people can schedule their times. They can just type in their times, or we can put times for them to choose from. We just haven't enabled that in the platform at this point. And so that's what's been helpful. Here's a patient who I took care of who was wrestling with his 2 sons. He's got teenage sons. We're all cooped up together, and they start wrestling. I've done this about 100 times. And he presented with he's like, hey, I felt a rip in my chest. And we were able to see this on telehealth. I did tell him, I said, by the way, I presented your injury before, but the person weightlifts a lot and looks like he's 20, but you're 45, but you'll be very flattered by the picture. But anyway, here's the bruising that's here. And I know that looks like a pectoralis tendon injury where the muscle pulls away from the bone from the chest muscle. And so we were able to get an MRI, and this black line here belongs over here. So I knew his injury with the MRI. So I never saw him once in person, but I was able to make a diagnosis, and we came up with a treatment plan for him without ever having to get together. And then here's another patient who suffers from severe Parkinson's. He's a young man, great guy, who was playing basketball by himself, socially distancing, but he exercises to treat his Parkinson's, and he felt a rip in his leg, and he tore his quadriceps tendon. He came to the office because he couldn't walk. He was in so much pain, and thank God he did. Because if he just sort of went home and splinted it with a towel and rested and iced it and all that stuff, he would have been miserable for a while, and then it makes this much harder to fix. And so this black tendon here belongs against the bone, but it's pulled away. So that needs to be sewn back to the bone. And this is actually tissue that's squeezed in between by accident. It doesn't belong there. This black tissue belongs out front. So it's just sort of, it's flipped down like this, and it really would never have healed appropriately or right. And this is one that obligates surgery for people to be able to walk normally. So these are some of the injuries we've seen. And, you know, I call them confinement injuries. Anybody who's seen Step Brothers will love this. But, you know, we see a lot of fingers and wrists and shoulders from people wrestling and messing around. But we're not seeing the femur fractures and the pelvic fractures from people in high energy car accidents. There are far fewer of them with everybody sheltered. And we're not seeing the sports injuries such as ACL tears or shoulder dislocations as frequently. We're seeing some, obviously. And again, thankfully, a majority of these injuries can be treated with splints and casts and braces and physical therapy. A small minority need surgery. And up until this week, this is the first week we've started doing elective surgeries. These injuries the ones that we were doing surgery on, pose a threat to life, limb, or critical function. So that gentleman who injured his quadriceps wouldn't be able to function normally unless we fix it. So we fixed it during, you know, even though we call that an urgent surgery. The person who hurt his pec, actually the pectoralis has a lot of redundant musculature. So a lot of people do very, very well without surgery. And so he opted not for surgery. But in the surgery, obviously everyone's mask green. It's actually like the safest environment you can dream of. It's certainly much more safe than going to the grocery store. And the surgeries, again, that we're performing are the ones that are going to be a real functional impairment. So we don't do an awful lot of life-saving surgery, but we do an awful lot of life-preserving surgery in terms of quality of life. And so these are the conditions that we have been treating. And now we're starting to do our normal surgeries. I have a couple of patients tomorrow that I'll be operating on with ACL injuries who've been waiting for 2 months. And, you know, they've just been waiting and waiting and waiting. We now have enough personal protective equipment, the PPE, to be able to move forward with some of this stuff. And then some of you may have seen this, most of you probably haven't, but this was a small ABC News segment that aired a couple of weeks ago. That's actually my father-in-law. That's my wife's dad, who's a judge and has been awaiting surgery because his was canceled in mid-March. And he's got a very bad back problem, and he has polio when he was a kid from the other side. So his leg that's affected is his good leg, but it's not so good right now. And he's just been waiting, and he's been waiting for surgery. And, you know, I think elective surgery is actually a misnomer, because really what it means is that it's a non-urgent procedure, but elective seems to connote that, oh, geez, this can wait, or it's, you know, it's some sort of cosmetic surgery, or that it's not covered by insurance. But the majority, 90%, 95% of the surgeries that are being performed in any hospital are typically under the term elective surgeries. It's just that you have the luxury of scheduling a time for the patient and for the doctor. Prevention of injuries, what we've been telling people, look, the obvious, don't get injured. But we've been using social media to, again, get our message out. So many of our physicians have posted videos to explain how to avoid injury during this time. What are some things you can do to get exercise? You know, you're mentioning sitting all day, and how that's, I have so many patients telling me their back hurts in the health visits because they're sitting all day. And it's exactly what's happening. So some of these videos are meant to kind of say, okay, here you can get up and stretch. Here's some safe things that you can do. And, you know, in general, the tips that we're giving, obviously avoid the confinement injuries. Be careful taking up new habits. I've had several patients coming in with big swollen knees because they decided to go running for 10 miles for the first time. And I totally get it. I totally get it. I'm actually kind of doing the same thing, but I've just decided to walk. and I walk 4 or 5 miles a day. If I feel like I want to challenge myself, I put a backpack on, and I figure I'm not going to get hurt walking, but people have gotten hurt taking up jogging, running, lifting weights. I've seen it all so far over the past 6 to 8 weeks. And I'm telling patients, look, start slow. You're not going to somehow transform into a marathon runner overnight. So just work your way up. Be very unambitious right now, because the bottom line is you don't want to get hurt. And then, like I said, walking, very safe, unlikely to get hurt, gives you the cardiovascular benefit, gives you the bone benefit of a weight-bearing activity. So I really stress, if you're going to do anything, go for a walk. And then, you know, many of you have heard my talk on the ortho health program that we run, but I think these principles are even more important during a pandemic where you're trying to keep your immune system well. And the idea of our ortho health program is to help our patients become healthier, to lose weight, so they wouldn't have so much pain in their arthritic hip or their arthritic knee or their bad back. And we've been emphasizing metabolism, like what factors affect your metabolism. So if you're tired all day long, your metabolism's low. If you're stressed out of your mind, there's cortisol is a stress hormone, but it's also a metabolic suppressor. People who eat diets that are filled with sugar, I'm hearing day after day and study after study just how poisonous it is. And sugar depresses your metabolism. It causes insulin to secrete in your body. And insulin is a growth hormone that doesn't make you grow tall. And then finally, like for safe exercise, you know, that's what I'm saying about walking. We just want exercise, not to burn 1,000 calories or 2,000 calories. We just want to get you moving, because if we can get you moving, that's really what helps your metabolism. So there's a sweet spot. And I think people's idea of what exercise is needed to help them be healthier is way, way overshot, actually. I think we can really start thinking, look, just simple movements, simple resistance, simple walking can be the exercise you need. So I think these principles that we have in our ortho health program are particularly important for keeping your immune system well, keeping your overall health well, so you can manage the pandemic better. And so we've been stressing this as well. And so that's the summary. That's the talk, basically. If you're injured, for our line of work, we're telling people not to ignore it. We're telling that we can create a safe environment for you because we're following CDC guidelines. We're trying to give tips so that you don't even need us in the first place. Here's some prevention tips. And we keep emphasizing for patients to take care of themselves, not to overdo it, get your sleep, eat well, manage your stress, especially can in this environment, and then exercise safely. You know, don't bite off more than you can chew. And we do let people know about the telehealth, but obviously our nuts and bolts of our work is seeing people in person. And so we let them know that these are ortho access places that they can come to. And we've had more people with higher level injuries coming through ortho access because they want to avoid the emergency room. That's actually totally understandable. And in fact, most of the hospital systems that we work with have asked us to do this because they don't want all of those people coming into the emergency room who would otherwise, with musculoskeletal injuries, and then be exposed to something else. So that's what I got. And I'm going to stop sharing my screen. And that's just really meant to be sort of a jumping off point for discussion. So we should unmute everybody. I don't know how to do that.
I will unmute everyone, and then if whoever has the piano player in the background could maybe stay
Dr. B.
muted.
Yeah,
Dr. B does.
it was Dr. B. She got it.
Okay.
I've got a question that's not a quick question. It's something you touched on early in your presentation. My brother and his wife are both hospice nurses, retired now. And he's consistently sending me information about DNRs and, you know, and I've got a pretty good DNR in place, and my son and I've got executor, all that stuff. And recently we were having a conversation where he was talking about the likelihood of getting off a ventilator with COVID-19, and that he and his wife have said that they absolutely will not go to the hospital. It's in their instructions, and they will not be put on a ventilator because they don't want to be alone, and they don't believe that there's a comeback from that. I'm 65 and I have asthma. I don't know whether I would want to do that and what the criteria is, other than my hospice Buddhist brother, that would help me make a decision. I mean, you said 60 to 80% are not coming off the vent, or 60 to 80% come off.
So wait, when did that?
So 60 to 80% is a number that's derived from data in New York, but also data here. And the data here is about 60%. So 40% of people do come off. And if I'm on the ventilator, give me the full court press. I'm not at a point in my life where I'm ready to pack it in. And so that's just my value right now. I would I'd want everything done possible. Some of the 80% data may also be coming from places that were using a lot of hydroxychloroquine and azithromycin, which hasn't necessarily been helpful at all. There was a lot of pressure to push it, and that's actually gone by the wayside. And so, and then there are other therapeutics that may be helpful, like the remdesivir. There's some places, I was on a Zoom call with a group of orthopods, and orthopods are known as strong as an ox and twice as smart in the medical community. But the fact of the matter is, we've been hearing things through the grapevine. One center is doing X-ray radiation to the chest, and they're doing radiation to the chest, radiation therapy, to create the immune system not working normally, to basically kill the white blood cells that are causing this tremendous inflammatory response. And so that was a therapy that had been used for tuberculosis, 6-7 decades ago. And so a lot of therapies that have been used previously are sort of being trialed around just to figure out a way to get people through the most severe part of the illness, which is this inflammatory response that really crushes the lungs. It fills the lungs with water, makes it like a sponge, and makes it very difficult to move air. What most places
for
are—
someone with this with asthma kind of disease or bronchial issues, that is terrifying to hear.
Of course it is. But what they've been doing is they've been rolling people. They've been doing everything to keep people off the ventilator. But because it requires so much manual work to do it, you're really burning through healthcare personnel. Like, they just get physically tired. They get emotionally overwhelmed. It's a very isolating illness because people aren't coming into the hospital. So it's been a really, like, I have never seen anything. Even HIV, which was, I was training in the 90s, and HIV was very much on the forefront of people's minds. But if you protected yourself with universal precautions, that's where sort of that all came from, you were pretty much in good shape. And the patients were not made worse with whatever procedure you did for them because they had HIV. And that was a very slow illness for a lot of people. But this is such a rapid onset illness for people who get very sick, and then they have to be isolated. And so it's like nothing I've ever experienced. It's the isolation of the people receiving care, and then the isolation even of the caregivers. There are reports of some of the caregivers sleeping in their cars so they don't go home and expose their family. And they've been doing this for a couple of months. And so it's the frontline. I don't consider myself anywhere near a frontline worker. We're very much backline workers. We're here to offload the hospitals. We're here to kind of take care of the stuff away from the hospital so that they can do their thing in the hospital. And even in the back lines, you feel a little bit of the stress, but nothing like what they're experiencing, where it's right in front of them day after day after day. So I don't know how to answer that. I don't know if I answered it for you, Betsy, but I got to tell you, like, it's a very much an independent decision. If you get on a ventilator in this area, you still have a 40% chance. So I look at that. I'm an optimist, so I look at that as a coin flip. Okay. And so that might be,
thank
worth
you.
it.
Yeah, I like those odds a little bit better than the 80-20.
Of course, yeah.
So we do have some questions in the chat. One is, do you think it's safe to have people come to your house for repairs or cleaning? And what do you recommend? Do you recommend being there? Do you recommend being outside of your house? Do you recommend them wearing masks, rubber gloves, all that?
So yes, and yeah. The answer is, if you need something done, you get it done. I certainly just like the elective surgeries. If there's something in your house that's sort of like a touch-up job, I might just wait on that. But if your pipe bursts or your water heater breaks, you need to have people come into your home. And you can absolutely insist that they wear masks. You can provide them a mask. You can absolutely insist that they wear booties on their feet, that they wear gloves, that you provide a place for them to wash their hands or hand sanitizer. And you can just say, listen, I'm going to give you the direct path to where you need to go. I'm asking you to leave. If you need to use the bathroom, let's make some different arrangements. And then you clean up after with some disinfectant. And the CDC has a list of appropriate disinfectants. The easiest one, quite honestly, is diluted bleach. So that's just the formula is 4 teaspoons of bleach in a quart of water. And you can spray that everywhere, and it kills the virus. It smells like bleach, which some people actually welcome when you walk into their business. It smells, like I said, it smells like a swimming pool. I kind of think back to that Robert Duvall line in Apocalypse Now. I love the smell of napalm in the morning. You know, people really might love the smell of bleach as they come into your establishment. And so, yes, I think people who are in the line of work where they're actually going to a house need to put a front and center. This is what I'm going to do to keep your home safe. But you have to view everyone as a potential vector, someone who might have the virus, who might spread it. And then you have to take appropriate precautions to protect yourself and assume that you're a vector and protect them. So we wear masks not for ourselves, we wear them for our neighbor. You know, we wash hands for ourselves and for our neighbor. But we're wearing the masks right now for our neighbor.
What was the formula again? 4 teaspoons to a quart?
It's four teaspoons to a quart. But if the CDC has literally a whole flow chart, a whole table of disinfectants that you can use. Bleach being one of them, ammonia being one of them, isopropyl alcohol being one of them. And so there's a whole list of it. And obviously there's some that are more gentle on skin than others, but the CDC provides a tremendous resource.
Thank you.
I think we also had some questions submitted in advance.
Yeah.
One of them, Peter, had emailed me earlier today. Do you know Peter? Because he's asking if he needs a knee replacement right now.
No. I actually basically, it's getting close to time for that, and you answered it in regards to the elective or non-essential area. Really, the question is the follow-up physical therapy.
Yeah, it's a great question. So obviously we're running the flow of patients through our physician offices and through our physical therapy offices is slowed, and we're spacing people out, and we are also providing telehealth. What's been really interesting is talking to the group of therapists, because they found the telehealth to be a really useful tool. And so like any tool, if you use it correctly, it helps you. If you use it inappropriately, it's a bludgeon. It doesn't help. But they've really found that the telehealth to be a platform where people can still do part of the rehab. So a lot of people have been splitting time between coming into the office once, telehealth another time, some sort of frequency of both that works for them. So we have those services still there, but they are in shorter supply without a doubt. The surgical patients are being prioritized to some degree. Every patient can be addressed, but I can't say that it's ideal. It's the new normal. And so if you have the option to wait, if I have arthritis in my knee and my knee's swelling every day and I can't walk around and I can't get up and down the stairs and none of the pills are working and I'm absolutely miserable, I'm going for my knee replacement. I'm going today for it. But if I'm able to manage, if I can get from 3 months of relief from an injection, if I can get a couple days of relief from a little bit of Advil, if ice helps me, if I'm still able to get around, I'm just a little miserable doing so. For me, I would wait. And again, these are value judgments. You do need to know that the services are there. They're just not in as great a supply as they were back in February. I mean, it's just a couple of months ago.
I've gotten to the point where I've been waiting for the last 3 years because I can get around. I can do all that. It's just that now it seems like a good time because I can't go to work and blah, blah, blah.
Super interesting. Yeah, a lot of that's the other part of this is that the irony has been during this last 8 weeks that we've been shut down from elective surgery, there could not have been a better time. Yeah. There could not have been a better time for people to get a carpal tunnel procedure. Couldn't have been a better time for someone to get their knee cleaned out. I mean, that's the shame of it, is that this 8 weeks that we've been collecting PPE appropriately, keeping people away appropriately, making sure we had enough ventilator supplies appropriately, was still the best damn time for people to recover from many of the procedures that we do, just like you're saying. So it's been like when we've been asking people, would you like to proceed with surgery this week? There have actually been 2 camps. Some are like, I'm going to wait. I want to see where this is going with the pandemic. And the other half is like, I would have done it yesterday if you had offered it. And so that's what I've been experiencing as we've been scheduling surgeries over the next month.
How are you guys? I'm sorry, I have a question.
Yeah.
Can I ask a question? Megan, am I allowed to ask a question?
I will allow it.
No. How do you know whether you guys are, how often do you get tested as folks in the office, folks in the staff? How often are you tested, and what happens if someone is tested positive?
So great question. We are not routinely tested because there are not enough tests. And so we are screened every single day. So we're screened with questions and we're screened with temperature checks. So could someone be carrying the virus? Yes. Everyone is masked. So if I have the virus and I'm masked, then I'm protecting you. Not fully, but protecting you. And if then the next day I run a fever, I can't come in the office. So in essence, that decreases the exposure risk, but nothing will make it to zero like testing. And so all of us are faced with the dilemma of not having enough tests. And so we do the next best thing, which is the screening and trying to see if you have any signs of it. And the problem with that, as we all know, is that the virus can be silent for 2 to 14 days or be completely silent. Some people have it and have no symptoms. And so the answer to your question is, I wish everyone were tested. I would love it if that were the case. We are testing our patients preoperatively, and there's the Illinois Department of Public Health has mandated that this happens. I'm actually not sure it's providing any purpose other than the very few people who will be COVID positive not getting an anesthetic, in other words, not going on a ventilator. But other than that, I think that the screening and the questions have been as effective as we can be. The testing is about, like I said, 70 to 80% sensitive. In other words, if you have it, there's about a 70 to 80% chance your test will come up positive. But we just don't have the tests right now to be able to test everybody routinely, even in the healthcare setting.
So are there protocols for folks who are working in the office to be quarantined? Like, I won't say sleeping in the car, but in that.
Yeah, no, any office. So someone in our office who has an exposure, they are quarantined, or someone who has it and anybody they've been exposed to, and the exposure isn't sort of, I pass by this way. It actually is about 10 minutes of close contact. That's what, again, Fauci will be talking about. But if you've had some reasonable amount of time where you've been in contact together, then that person needs to be quarantined as well. Ideally, you would actually take someone who had close contact and then test them. And if they're negative, on they go. If they're positive, they quarantine. So that's where the value of contact tracing comes in, is that it can be much more judicious with this very precious resource of tests. Now, the antibody tests, as we mentioned in that numbers game, will become a lot more useful as we move along within the pandemic. So if you do have a flu-like illness or someone in your family had it, I actually saw a patient today, this week. His daughter came back from Spain from a semester abroad. She had it. His wife got it. Everyone's fine. They had a mild case of the disease. He got swab tested 3 weeks after and was negative because he wasn't carrying the virus. So the swab test is answering the question, do you have the virus? But then he got antibody tested, and the antibody test came back that he has antibodies. And then those patients who have antibodies, who tested negative, they will not be able to donate their antibodies to help somebody else out. But those people who tested positive to begin with, who have antibodies will, just because it's like a double layer, a double screen. My guess is as we go along, anybody who tests antibody positive will be able to donate their antibodies because we're going to be in need of it. But right now, you have to have both the swab test positive and the antibody test positive to donate. But the good news is for this family is basically everyone's had it, and they're on the other side. They're the people all of our families want to be, where they had mild disease and they have antibodies. And though we don't know whether that confers immunity, it certainly seems to be better than not having any antibodies at all.
I don't understand why, if you have the antibodies, but you didn't test positive because you didn't test in time, why they wouldn't still want your antibodies?
Because there might be a false negative, there might be a false positive in the test. And so if you have 2 tests that show that you had it, that's better than showing 1 test. So it's we do a lot of sieve construction in medicine, where if you make it through 1 sieve, there's another sieve that you have to make it through, and it's a way of avoiding mistakes. So I really think you're absolutely right. It would make sense to be able to give those antibodies. but
Yeah.
they might be testing positive because they had a different coronavirus, one of those other 4 that are harmless or something. So it's like a false positive result, and they actually don't have anything. And then that very sick person who's looking for antibodies, you think you're giving them antibodies and you're not. So it's just a double layer of security. So it's that idea of a sieve, catching it.
PJ has another question, and I guess we have to allow it. He wants to know, how do we get a reliable
I'm going to sit in his waiting room
antibody
tonight.
test?
I'm going to sit in his waiting room tonight, and I'll just wait for him to answer my questions.
So say it again.
PJ wants to know, how do we get a reliable antibody test?
So right now, the way that they're figuring out how reliable an antibody test is when someone has had a clinical case of COVID that they know, they've documented with PCR, and they've had the whole clinical spectrum. They'll take their blood and they'll do what's called an ELISA test, which has been the gold standard for detecting antibodies. And it's a very special test where you put fragments of the virus onto a plate, the antibodies stick to it, the antibodies are tagged with some glow stick essentially, and you can tell, okay, this is a positive test. And that requires a whole vial of blood going into a laboratory to do that. It's called an ELISA test. And if you can Google it, you'll learn more than you ever want to know about it. That's an ELISA test. That's a gold standard. And even that has some false negatives. It's not perfect. So there are people who've had the illness clearly. They had the syndrome, they had the PCR testing, who are antibody negative. Though they probably do have antibodies, they're just not testing positive, okay? But that is about a 90-95% good test. The finger stick tests, every manufacturer of it will say, we're 95%. But when you actually compare it to an ELISA test, it's been ranging anywhere between 60 and 80%. So the finger sticks have a long way to go. They've been flooding the market because the FDA sort of took away the regulations of them. They said, go ahead and make your test and put it out there. And now they're rolling that back. The FDA is starting to look at the efficacy of these tests because they don't want to give people a false sense of security or give them the wrong answer that you don't have antibodies when you do. So there's been a little bit of a rollback on the FDA side. But the best blood test is with an ELISA test, but they're really restricting those because there are only so many resources and so many reagents. And we're using that to identify people who could give their blood to patients who are very ill. So, and some places are using it as surveillance, like, geez, how much do we have in the area? So Stanford did that in April. New York did it recently. So when you see these CNN or Fox News reports about it being 2 or 3% in California or 15 to 20% in New York, those are the antibody surveillance tests, and they're just sampling. Now, they might be actually overestimating it, because if you did have a flu-like illness and you see this advertisement that you can get tested, I'm driving over there. And that's how they recruit patients. So there might be a little bit of a recruitment bias that goes on. But anyway, these are the numbers that are leaking out. They're not perfect by any stretch. But we're not at the point where, if you get 50 to 60% of the population infected, then the virus has a harder time finding the next host. So it slows down naturally. That's this concept of herd immunity, of slowing it down. But where we are now, the virus can spread very rapidly from one place to the next, because most of us haven't been exposed to it.
Good question.
Yeah.
So I was recently tested for COVID by North Shore, and they did not do it through my nasal. They did it by a throat swab. Is that
Yes.
just as accurate?
So I actually don't know the answer to that, but I know that because so many people hate the nasal swab and find it difficult to tolerate, that the second choice has been the oral pharyngeal swab. And now people are actually doing their own oral pharyngeal swabs. Quest provides a test where you do it on your own. That's the one that we've been using now for the past week for our pre-op patients. I can't tell you whether it's more or less accurate, but it certainly meets a standard where it's accurate enough. So if you're
Lori, I also had that test.
through the nose or through the mouth?
Through the mouth.
Yeah.
And it almost made you gag, right?
Yes.
Yeah. So they got back there.
Yeah.
They get back there in the mouth. I mean, the idea is you got to get way back in the throat, where we think the virus is more likely to reside than, in the tip of your tongue. And I'm sure the saliva test isn't just, you drool a little bit. I'm sure you're phlegming it up. You're really hawking a loogie in there. I don't think it's a very gentle saliva test either.
No.
But the idea is to get some sample from where you respirate and where you respire, so that you're providing virus into the test.
So there's the 25% rate of false negatives then. Is that going to get better as tests get more sensitive, or why is there such a high number of the false negatives?
Yeah, so I introduced a very confusing concept, as it turns out. But the test itself, a test has a certain amount of false positives and false negatives, and that is whatever the test is. But in that sort of in those parameters, when you get a positive or negative test, whether or not you can rely on that result depends on how many other people have false positives or not. And so if you get a positive test, but there are tons and tons of false positives out there, then you don't know how to interpret your positive test. Do you see what I mean?
Yeah.
So it's a funny statistical anomaly that that makes it hard at this point unless you have a perfect test. But what we have are imperfect tests. So we don't really find that getting your antibodies checked right now to be that helpful. It might be more helpful among healthcare workers or frontline workers who are more likely to be exposed to the virus. So their incidence might be 10 or 20%, not 2%, just because they're around it more. And so most people are sheltering in place, they would have a normal low percentage risk. So that's something called pretest probability, where you're trying to stack the odds that the test is going to be meaningful. So the answer is, I'm glad you got the oral pharyngeal swab. I don't know whether to hope it was positive or negative, to be honest with you, Lori, because if it's positive and you look as great as you do, great. And I hope you had that test 4 weeks ago and it was positive, because then you're through the woods. And if it's negative, then you're in the same boat that probably all of us are, 90% of us are, which is we got to figure out our next step into the world where we can be productive, be helpful, and but protect ourselves and protect our neighbor. So like, just at a time when our country seems to be like the most divided, like, man, we really need a collective effort right now.
Yeah.
And so that's the part that, you hope that, as a crisis not going unwasted, maybe that'll be the silver lining, that we actually can start, working together. It shouldn't matter if you're young or old or red or blue or diabetic. I mean, everybody should be like trying to get through this as best we can without getting sick ourselves and without making our neighbors sick.
Absolutely.
One final question. Should we be donating blood if we're healthy? Do you recommend that?
So I always recommend donating blood because there's always a blood shortage. I think the environment that they've created for blood donation is incredibly safe. And among COVID, they're sort of recruiting the safest patients, the ones who've already had it, been through it, and are antibody positive. So I don't think the atmosphere, where people are donating blood is an unsafe environment at all. But again, I wouldn't necessarily take on increased risk if someone in my house were immune compromised or severely diabetic or a severe asthmatic who's been intubated. And you've got to assess your own individual risk. And so that's part of the whole calculation. So should you donate blood? The answer is, uniformly yes, but it's qualified in the setting of this pandemic of what are your personal risk factors, what are your family's risk factors, and in a way, whether it's donating blood or going shopping at your favorite store or going out for groceries, it's that calculation that you're sort of subconsciously making all the time.
Thank you. So I think that was the last question. PJ, you're done?
How long will I wait in the waiting room is what I want.
Well, so I'm glad you asked that. We are a lot less than you did the last time. That's all I can tell you. So because we're trying
I don't
to
wait in
make
the
sure.
waiting room. I go see Dr. Amy Jo by myself, so I don't wait in the waiting room.
She's awesome. But the fact is, like, all of us are trying to keep people in the waiting room as little as possible. We actually are having fewer doctors see patients on any given day so that there are more spaces available in the waiting room where we've reduced our schedules so that people can get to the waiting room and then into the room as quickly as possible. And again, you'll have that napalm smell of bleach when you walk in. I mean, it will hit you a little bit. And the only thing I've heard about patients with that is thank you so much. I've never heard someone say, oh, it's burning my eyes. Can you tone it down? Everyone's been saying, thank you.
I have an idea.
Yeah.
Because of course, Betsy, I have an idea for marketing for you guys. You ready? Send out mailings with a scratch and sniff with bleach saying we're ready.
That's a great idea.
Okay, PJ, that's a good one. That's a really good one. That would make me feel safe. But now I have a question for Lori, actually, and I don't know, Lori, maybe I'll have to ask Marianne. Now that I'm on Medicare, because I'm old, can I go to IBJI instead of only being able to go to North Shore? Can I?
Yep.
All right. Get ready, Dr. Chehab. Yay.
Okay.
So I just want to add by the end of this too quickly, if you have more questions for Dr. Chehab after this, I'm going to put my email address. You can send any questions to me and I'll be happy to follow up with you. So,
yeah. And if you know Lori's IBJI email, you know mine too. It's just eshehab@ibji.com. So it's very easy to get a hold of either one of us.
Thank you both so much. Thank you, Dr. Chehab, and thank you, Lori, for coordinating this. We really appreciate it. We love hearing from you guys. We love our relationship with IBJI and hope to continue many more sessions like these if we can. So thanks so much for your time. We really appreciate it.
Thanks for having us.
And
Thank you
Charlotte
for having
Bishop,
us,
it's a
too.
treat to see you. Hi, Char. We'll have to catch up soon. And Liz, brunch. Sometime. You're gone now, Liz.
She hung up on you.
She did. She doesn't want to have brunch.
Chamber folks, I have a question. What's the protocols for tomorrow night?
What do you mean? Get on the call?
Are we dropping off Corona? Are we keeping Corona? What are we doing?
I haven't heard anybody asking for a drop off. We've told them all where to get it. We've said if you want to drop us, let us know. We haven't heard anything from anybody. Pat, I'm assuming you haven't heard anything from anybody?
No, I haven't.
Okay. All right.
Okay.
Yeah.
So,
And Charlotte, you can stay on and we can talk after everybody hangs up.
okay.
I'll stop
So there's
recording.
nothing we need to do. We just need to go